Hello and welcome to the print video. I am Sumi Sukanya Datta and you're watching Health in You. So Kerala has been seeing a lot of cases related to brain-eating amoeba or what is called amoebic meningoencephalitis. These cases have been reported in the state over the last few years, but over the last few weeks particularly, there has been an alarming rise in these number of cases and deaths. So this year so far, there have been 69 confirmed cases of this disease as well as 19 deaths. To discuss everything about this particular disease, what the symptoms are, how this spreads, as well as the outbreak in the state, which has really scared the entire country, we have two experts with us, Dr. Araving Reghukumar and Dr. Rahul Chawla. Dr. Reghukumar is an infectious disease specialist with Government Medical College in Thiruvananthapuram. He's also one of the members who is part of the task force which is guiding the government policy on this outbreak. And Dr. Chawla is a neurologist with Healthpil in Delhi. Thank you so much, Dr. Arvind and Dr. Rahul, for being with us in the show today. So we'll start by asking you first, Dr. Arvind, since you are there and you are in the middle of the action, you are also seeing how the government is responding. You're part of this outbreak management there. So please help us understand what exactly is the situation there, and can you please take us through the outbreak management at the moment in the state?
Actually, from 2016 onwards, so we have been getting cases of the primary amoebic meningoencephalitis in the state of Kerala. It used to be, say, one case or two cases per year till 2023. So that is what is happening in the rest of the world in other states in India. So probably it's very sporadic. It's a very rare infection, 1 to 2 cases per year. Then in 2024, we started getting increased case detection happen, especially in North Kerala. And probably we attribute that to one reason, because we are a Nipah sort of endemic area, especially in North Kerala. So we have insisted that all cases of meningoencephalitis should have an etiological diagnosis.
Right.
So that is very, very important. So Nipah is also part of the testing. So if Nipah testing is also negative, so we do all the bacterial panels, the viral panels, and then when we don't get a diagnosis, we search for amoebic meningoencephalitis as well. And that is how last year we identified till around July around 8 cases of amoebic meningoencephalitis in North Kerala. Interesting aspect was that of the 8 cases, around 50% survived. All of them are pediatric cases. Why this is interesting is till 2023, all the cases diagnosed in the state had died. So usually we know that in primary amoebic meningoencephalitis, the mortality is around 98 to 99%. But till July 2024 last year, we were able to save around 50%. So when we analyzed the data, we found that earlier the diagnosis, the chance of survival was higher, especially in these kids. If the diagnosis was made, say, within 3 days, they were surviving. And if that was made, say, after 4.5 days, they were actually dying. So we understood that we need to have a very, very, high index of suspicion to diagnose these cases. If there is a history of contact with pond and all, it's very easy. But in many cases, there may not be a direct link, etc. So this is what happened in North Kerala. At that time itself, we asked, so why, if the cases are there in North Kerala, why this is not happening in South Kerala? So the answer that we gave ourselves was that, probably, they are the Nipah endemic area. So they are actively looking for etiological diagnosis in cases of meningoencephalitis. At that time, it's even 8 cases, from an area in 3 months is pretty odd when you're looking at the global average, etc. Then actually, if you're looking at the clinical profile of meningoencephalitis globally, in this molecular era and the genomic era, only around 50% of cases are having an etiological diagnosis. If you're looking at data from India, except from the research settings, only around 30% of the meningoencephalitis are having an etiological diagnosis. And we have studies published from AIIMS Delhi in 2020, which looked at around, say, 300 cases where etiology was not identified. Around 1% turned out to be due to Negliaria. That is the etiology of primary amoebic meningoencephalitis. And the brilliant study published from the parasitology department in PGI Chandigarh in 2022. They actually looked at 156 samples from the brain fluid, the cerebrospinal fluid, and they in which all other etiologies had been ruled out, the viral, etc. And they identified this amoeba in 11, of which 6 were due to acanthamoeba, 2 due to Negliaria, and 3 due to the Balamithia. That shows that probably if you are going for an active case surveillance mode in India, So around 6 to 7% of cases might turn out to be amoebic meningoencephalitis. And interestingly, Kerala was not the first locality in India which started diagnosing and identifying all these cases. A lot of publications from East India, especially from School of Tropical Medicine and medical colleges or other institutes in Calcutta, they started publishing from 2023 onwards. This year itself, they have published a case series of 10 cases of academy by immunocompetent, etc. So their take-home message from the publications from School of Tropical Medicine were that in India, since majority of the meningoencephalitis don't have an etiological diagnosis, it is prudent that we rule out amoebic meningoencephalitis even in patients who are not having an epidemiological link. So when we got these 8 cases last year till around say July, so we actually adopted whatever has been published by the PGI Chandigarh as well as the School of Tropical Medicine, and we actually started active case surveillance. And then we got this cluster of cases in Trivandrum, that is South Kerala. So you have it in North Kerala, you have it in South Kerala. So we issued the technical guidelines, that is in July 2024, and a CM convened a meeting. So last year itself, the Chief Minister had convened a meeting. And then the technical guidelines were issued. And at that time, miltefosine was actually not available for treatment of amoebic meningoencephalitis. So state, reached out to center, and now our the treatment cocktail includes miltefosine as well. So probably we believe that was a game changer, especially for Naegleria infections, because in Naegleria itself, now mortality is only around 25%. If you're looking at the global average, it is around 98%. So this cocktail was made available by the state, and the treatment protocol was there from say July 2024 onwards. And then in September 2024, we conducted a One Health workshop because we need to understand why this is happening, right? So Kerala, the problem is that usually in primary amoebic meningoencephalitis, the route of entry is through the nose. And in the granulomatous amoebic meningoencephalitis, like due to acanthamoeba, balamythia, sapenia, paravalcampia, etc. So one route is through the nose, and you can also inhale, and from the lung through hematogenous spread is there, and sometimes through the wounds also, especially in immunocompromised.
Right.
So this water is implicated. So we need a One Health approach. So we conducted a One Health workshop with all the stakeholders and had experts from ICMR, then the Dr. Rakesh Segal, Indian Institute of Science, etc. And we drafted a One Health based action plan last year. And one important part of that action plan was that we need to go for an active case surveillance. So in some cases, even in those which were reported from Calcutta, they were not able to find a classical epidemiological link, like linked to a water body or something like that. So we said that in any suspect case of meningoencephalitis, if you're not able to find a diagnosis, you need to rule out amoebic meningoencephalitis as well. So, and this was practiced in our state from this year onwards, and that is the reason why increased case detection is going up. And why we did that is because the earlier you diagnose, the chance of saving the patients is also pretty high. So that is what is happening in Kerala right now.
Yeah, thank you so much for those insights. Dr. Rahul, can you please help us understand? Dr. Arvind talked a lot about what Kerala is doing and how cases are being identified very actively at the moment. But can you talk a little about the disease itself? What are the symptoms, for example? Are the symptoms same here in the patients that we are seeing, of this condition here as compared to those in the West or in the rest of the India?
So amoebic meningoencephalitis is basically infection of the brain parenchyma and the covering around it. So the presentation of all the meningoencephalitis syndromes, whether it's viral or it's bacterial or even it's because of amoeba, the initial presentation can be similar. So that is the major problem, that initially patient might just have fever, headache, vomiting, seizure. And this is how any brain infection or even brain inflammation presents like. So in isolated cases, it is very difficult for anyone to spot that this could be amoeba. So what we do is that whenever this patient comes to us, fever, headache, vomiting, depending on the country to country basis and regional basis, we do have possible differences. So these are the possible differential diagnosis, and accordingly we have to treat the patient. Many a times we just do the CSF study, that is cerebrospinal fluid, and we check the level of cells, proteins, sugar, and various markers of particular diseases. And then we start the patient on empirical treatment. That means without even waiting for the results, we start the patient on empirically agent for considering it to be a viral agent. We'll start antivirals. We'll start with antibiotics. We may also
basically symptomatic treatment depending on the symptoms that the patient has.
Considering it to be a meningoencephalitis, could be viral, could be bacterial. we start the patient on treatment, because all these meningeal encephalitis syndromes are could be fatal, could be deadly, because the brain is involved, could have multitude of complications. So we don't wait for the results, we even start the treatment. Once the results started coming in, we can see, okay, we have ruled out tuberculosis, we have ruled out bacterial, it looks like viral, we'll continue with the viral. Okay. Many times we wait for the treatment, many times we start the treatment empirically. Now, in isolated cases, usually people don't think about amoeba as a differential because it's a very rare entity. I'm not really sure how many cases, but probably not more than 1,000 or 2,000 cases must have been reported worldwide. Okay.
It's that rare.
It is that rare. But the good thing is that it usually occurs in outbreak. If that amoeba is present in a freshwater source, usually it's found in a tropical climate, warmer environment, because it's a thermophilic amoeba. So not a single person would be involved. It's like if a single person is involved, more likely more people are also going to be involved in coming days. Okay. So if you have an outbreak and you have seen 2 or 3 such similar patients, next time any such patient comes, definitely amoeba is going to be your differential. You are going to manage this patient keeping into mind this could be amoeba, and in the CSF you will send a specific test for amoeba also. We can actually see the trophozoites of that amoeba inside CSF. But otherwise, for any person, like if a patient with meningeal encephalitis syndrome comes to me, I won't consider amoeba as a possibility because it is rare. But in Kerala, because it's now happening as an outbreak, they would be considering that as a differential. Immediately, the testing is done and the patient is started on treatment. So if you are able to diagnose the condition within 3 to 4 days and start treating it, definitely it can be treated. But the problem is that usually it is not considered as a differential because it's a rare entity. Usually we start patient on other treatment. When they don't work, then we think, okay, there is a history of swimming, maybe we can consider amoeba, maybe we can send a sample for that also. Then it comes out to be positive, then we start the treatment. But by the time 7 to 8 days have passed, complications have already occurred. Now it's difficult to save the patient, and hence the case fatality rate is increased. So 90 to 95% when we talk about the case fatality rate, it's because it's difficult for us to even diagnose and treat timely. Okay, and the drugs also need some time to start having some action. And meanwhile, if the complications occur, it's difficult to save patient. So that's why it is a very fatal disease, and we have to look into any symptom that the patient may have. Talking about coming back to the question that you asked me specifically about the symptoms. So any meningeal encephalitis syndrome, patient may be having fever, headache, vomiting, seizure. Then patient may have behavioral changes, patient may get irritable, patient may not respond properly, patient may become mute, or patient may have certain neurological deficit like paralysis. Maybe one side of the body is not working, or patient has turned completely mute, or there is some difficulty in balancing. Okay. Then next cases, patient will turn comatose. Patient will stop responding. So this is how it usually progresses. And apart from that, there can be some other complications, like maybe there is some increased brain edema that can lead to shutting down of the major critical brainstem structures, or there is hydrocephalus. Many complications can be there within 7 to 10 days span. If we are able to diagnose and treat timely, the results are going to be good. Otherwise, it's a fatal disease.
Thank you so much again for that information. Dr. Arvind, every time there is an outbreak, and invariably we've been seeing that Kerala has been at the forefront of, detecting these kind of diseases, the tropical diseases. And, people usually end up asking why Kerala. Again, there is a disease being detected in Kerala. Why there is another outbreak in Kerala? So what exactly is your response to that? Do you think it's because the state is actively identifying and diagnosing these diseases? Or is it because, because of the effect of climate change, as you touched upon this topic earlier also, is more visible in the state as compared to many others?
You cannot blame climate change for something which is apparently localized to our state alone, right? So as you rightly pointed out, if you're looking at all the emerging infections, like maybe COVID or say Zika or Mpox, seems as if Kerala appears to be in the center of it. This is because two things. One is active case surveillance, and second is because of transparency. Okay. So here, whatever is reported means by the treating team, it will be reported by the government as well. Okay.
Yeah.
So that's the most important thing. That's why we said, Kerala strategy is based on inputs from other states. We're looking at the study from PJ Chandigarh, which is in the north of India, right? We are looking at the studies from Calcutta. We are given reference of their studies in our action plan. Okay, that is from the east of India, and we are at the south, right? So we're looking at India as a triangle. A lot of other states also have started. Academic institutes have started picking up this amoebic meningoencephalitis. Another thing we need to understand is that this brain-eating amoeba is a misnomer that applies only to Naegleria. And if you're looking at more than, say, 100 cases reported from our state over the last 2 years, only 11 had been due to Naegleria or this brain-eating amoeba. In that itself, the mortality, we could lower it from 98% to 25%. Whereas the rest were due to this acanthamoeba. Acanthamoeba in immunocompromised, the mortality is high. It's around 60 to 80%. But in immunocompetent, the mortality is not very high. And the presentations could be disarray presentation. Like you don't require all the 5 drugs, which are indeed toxic also. So we revised our action plan and made it a customized action plan. So based on the symptoms, based on the neuroradiological appearances, presence of increased ICP, and based on the particular amoeba that is causing the problem, so we are using different regimens. So all these things were made possible because of the molecular diagnosis. So last year we were reliant on PGI Chandigarh as well as AV Institute for this molecular diagnosis of amoebic infection. So once you are getting this molecular identification of the amoeba, you can actually streamline your treatment and you can use less toxic drug sort of thing. So this year, our state public health lab started its own molecular facility so that we can identify 5 species of amoeba like Naegleria, acanthamoeba, Balamuthia, Paravalcampia, and Vermamoeba can be identified in our own PH lab. So this actually has helped us in increasing the case detection because our PH lab can do the molecular work, means there is increased pickup rate. And that also helps us in selecting the less toxic regimens, tailored regimens, etc. So that is of the help to us. And we are actually just like in Frozen, what Elsa said, we are actually bridging building the bridge as we walk, because everything about this parasite is really not known, because there are a lot of publications from China, etc., saying that in the post-COVID era, these amoebic infections, amoebic brain infections are increasing. And one postulate is that in SARS-CoV-2 infection, also the olfactory bulb was affected, and we all also had anosmia, etc. So the mucosal integrity. So majority of the people living in and around these contaminated water bodies may be harboring this amoeba in their nose. That is colonization. That is not invasion. And it used to be so rare or so sporadic because of 2 things. One, the case detection. We never had these molecular tools, etc. in the past. Second is probably our mucosal integrity used to prevent this amoeba from getting in. But this hypothesis there, which is very difficult to prove, because majority of us, all of us did have COVID. And we have been studying these patients with there's amoebic meningoencephalitis in our state, and they never had severe COVID or anything like that. So a lot of things we are studying, this epidemiology, how some people are developing this infection. When you're looking at water bodies in the state, we have around 55,000 pounds and around 55 lakh wells in the state. So getting an epidemiological link in Naegleria is very easy, because Naegleria, the incubation period is only 7 days. Whereas in acanthamoeba, the incubation period, really no one knows. It could be from weeks to months. So blaming a particular water body for acanthamoeba is not scientific practice. So that is a challenge that we are facing. And from whichever water body you sample, you are likely to find these are free-living amoeba, because it's supposed to be there. And this global warming can be blamed only for thermophilic amoeba like Naegleria. We can't attribute it to acanthamoeba, because acanthamoeba can survive in any environment, including the seas, Antarctica, etc. Acanthamoeba is there, is ubiquitous. So a lot of challenges are there, especially with regard to the increase in number of acanthamoeba infections in the state. And that is the reason why, a lot of cases we could identify only well as the source. Saying well is the source, it's sort of far-fetched, right? A lot of people in the country are using wells as their source of water. And we have 55 lakh wells in the state. And last month on 30th and 31, under the leadership of our CM, a One Health-based chlorination of all the wells in the state was undertaken. Around 27 lakh wells were chlorinated. But this is not the solution. The solution is actually creating awareness among the people. So that we have been trying to do from last year onwards, when the guidelines were released. It's very difficult to keep the care lines of water bodies. All the children love jumping into the ponds, etc. But once infection is identified, then the local self government is putting boards like this water is not safe for use, etc. Then there are a lot of other practices like religious ablution is there, putting drops into the nose of infants, etc. and all those things. So on a case-by-case basis, we are modifying the guidelines and giving targeted awareness to the public. I believe that in the long run, we could need to learn to live with this amoeba. So basically, adopt safer practices while diving into the ponds as well, and ensuring that. And the Public Health Act was revoked. Public Health Act in the state was invoked to ensure that all the swimming pools as well as the theme parks, they are chlorinated regularly, and they have to maintain a register showing that the chlorine levels is residual chlorine is between 1 to 3 milligram per deciliter. So all these things are being done, but 55 lakh wells and 55,000 ponds means there are issues, especially
Yeah,
with
that's a humongous task indeed.
Exactly.
Thank you so much for that information again, Dr. Arvind. Dr. Rahul, one question that probably many of our viewers will also have is that, while we're talking about amoeba, which lives in freshwater lakes as well as wells and this dirty water, as Dr. Arvind was saying, but, this is also being identified in patients who have also succumbed to the infection, who probably were not exposed to any sort of external, this kind of lake or ponds. For example, there was a 4-month-old baby, if I'm not mistaken, who has also died because of the infection. So, what theory or what understanding do we have about how this spreads, how this amoeba, infects people?
So this
Dr.
amoeba doesn't have human-to-human transmission. It doesn't spread by fecal-oral route. So if you are
Okay.
consuming a contaminated water and you are drinking that, you are not going to get amoeba because usually it gets killed in the digestive tract. Okay.
Mhm.
So human-to-human transmission is not possible. The only way it can get transmitted is via nose, okay, or via mouth if it enters. But somehow it usually the nose, okay, and it breaks up the cribriform plate and reaches the brain-parent canal. This may happen if you are taking a bath inside any of the freshwater body, or you are using. There are certain practices usually in Ayurveda where they do a nasal cleansing. So they pour water inside their nostrils, and the water that can go inside. Even while if you are washing your face with water, still that water can
Get into
get
the
inside
nose.
your nose. So with the infant, I'm not really sure what could have been the mode, but probably the exposure to water could be there. Maybe applying water over the face for cleansing purposes, and that could have led to the transmission. I'm not really sure about that, but that could be the possibility.
Dr. Arvind, would you like to add something there?
Actually, with regard to that, asking about that particular case, right? A
Mm-hmm.
4-month-old baby. Actually,
You're
okay.
right.
So there, that gives the means regarding that case, that was a major issue in the state. Now, how you can have a 3-month-old baby getting infected with this Naegleria fowleri, and just a
Mm-hmm.
molecular confirmed case of Naegleria fowleri. And literature says that from 15 days onwards, there have been case reports, okay, of children getting infected. And in this particular case, the Naegleria fowleri was identified by a solution which was put into the nose of the baby as part of your religious practice. So it is just been
Okay.
confirmed molecular. Okay, so basically Naegleria fowleri, finding the source is pretty easy when you are having a very strong surveillance system like what we have in Kerala. But in Acanthamoeba, I don't think even this surveillance system will be able to find the root cause in all the infections, because the incubation period is so varied.
Okay. So, can we also, you spoke a little about how post-COVID these kind of infections have probably, have risen or are expected to rise. Can you speak about why exactly is that happening, or is that likely to happen?
It's
Dr.
actually
Arvind,
just like a hypothesis, because you cannot blame everything on the post-COVID situation. This is just a hypothesis that we came across, because once you are dealing with a very unusual situation, I believe that if you're looking at 100 cases over the last 2 years, entire globe put together, I don't think 100 cases would have been reported. I think US report 1 case this year. That's all. So basically, when you are dealing with an unusual surge of infections, and that is not really an outbreak sort of thing. These are from different water bodies, different parts of the state,
mm-hmm.
etc. So when that is happening, we definitely go through the entire available literature in the world, right, regarding amoebic meningoencephalitis. We talk to all experts. We have talked with experts in PGH, Chandigarh, say experts from School of Tropical Medicine, because our aim is to bring down the mortality further, and also we need to understand the epidemiology. So the ICMR experts, all of them are there to help us, but then no one has this sort of experience, because no one ever had this sort of an outbreak,
So
right?
we have not been able to pinpoint exactly what exactly could be the driving force. Then suddenly, why
The
so
thing
many
is that
sporadic cases are happening?
out of these 100 cases in the state, only 7 could be attributed to a particular cluster, which happened in Trivandrum last year, and that was related to a high-risk behavior, vaping behavior. Other than that, the other, so around 95% of the cases are from different water bodies. So that goes in tune with what CDC has said. It's such a sporadic infection. So if some person takes bath in a Negleria infected pond, the chance of another person getting it is 1 in 26 lakh. Okay. And for example, if 5 crore people are engaging in water sports activities, only one will get. So that is actually that much sporadic. So outbreaks has occurred in Czechoslovakia from a swimming pool, or in, I think, Karachi with regard to nasal ablution. Other than that, these are sporadic events. In Kerala also, what we are seeing is the sporadic events are there. So outbreak in that sense is not really an outbreak. These are sporadic events getting picked up by the state. And there are different modes of transmission. If you're looking at the CDC modes of acquisition of Negleria, any, like using a water sprinkler in a kid, water gets into the nose, that itself can be a risk factor. That means that almost everyone has a risk factor, if you are coming into contact with an amoeba infested water. So in that context, so amoeba was there everywhere, right? So it is ubiquitous. Then if you look at the epidemiological triad, the agent, host, and environment are important. So agent is there everywhere. The environment always had this amoeba. Probably, if the water body is contaminated, like more coliform count, the more density of amoeba will be there. Then we need to look at the host factors. So in Negleria, it can usually used to affect the children because, their cribriform plate is porous, so that amoeba can directly go into the brain. And immunocompromised patients, they are at increased risk of acanthamoeba infections because, their immunity is not able to ward off this acanthamoeba. But what about the immunocompetent? So a big chunk of the people who are getting infected in the state are apparently immunocompetent with acanthamoeba. So that is why, we started searching literature about the, recent things. And there are a lot of reports saying that in post-2022, there is a surge in number of cases of amoebic meningoencephalitis in the brain, especially the case series from China of 47 cases, etc. So I believe that after COVID, our pickup rate has also improved because molecular diagnosis have increased like anything in our country as well. So that is a definite bias. So if you're searching the literature, there are certain things like alteration of the mucosal integrity as well as the widening of the tight junctions in the blood-brain barrier, which are supposed to prevent this amoeba from entering into the brain as well as into the CSF. So these are all postulates from different research articles, and these have not been proved. Okay. And from our experience, none of our patients had a severe COVID infection.
Okay. All these patients who have got this amoebic infection, you mean?
Yeah. We are actually searching out all the postulates, right? So this is something which we are keeping track of.
Okay. Very interesting. Dr. Rahul, if I ask you to, give us tips for viewers on, though we haven't in the current, over the last few months or few weeks, we haven't really seen cases coming up in any other part apart from Kerala. But still, since, there is a scare everywhere and people would want to know, if you can just, list some of the tips that people may practice in order to avoid this kind of infection, what would those be?
So first thing would be to avoid swimming in these kind of sources where there has been an outbreak. Now, there can't be a silent ban. You can't say, oh, okay, across India, let's ban all the freshwater bodies. Let's stop people from swimming. So that is not a feasibility. So the feasible option would be if you are using swimming pool for swimming, let's have a proper decontamination of that. That should be treated water. That is something that has to be done. Okay. What can be avoided is that if you have a freshwater body, a pond in a village, which must now not have been treated, avoid that if possible. Okay, because who knows, there might be a source of infection over there and you can get infected. Even though it's not occurring in clusters, there is not an outbreak, but a single case is still possible. That you have to consider. The other thing is whenever using water for rinsing your nose or whatever practices you are doing, make sure that the water is also properly treated. Maybe you can do that with filter water rather than doing that with the tap water. So that can reduce the chances. Ultimately, it all boils down to whether we have cracked the sources of such a contamination. And which is what Sir has really explained beautifully what is happening in Kerala right now. So when the cases have been detected, we need to localize what exactly were the sources, and those sources have to be completely cut off. They have to be decontaminated, and a strict advisory has to be issued at least in that area, especially in Kerala, in the zones wherein such cases are coming from. We can't put a blanket ban on everything across India, but these are certain measures that we can take. From
Yeah.
medical point of view, since it is a rare disease, this particular differential has also to be kept into consideration, especially if you are living in South India, in the neighboring states of Kerala, that this could also be a possibility. And any patient coming to with fever, headache, and seizures, amoeba should be kept as a close differential and has to be and should be worked upon. Rest, the
Yeah.
government advisories should be followed.
I'm sure Kerala already has these guidelines and is being followed in the state. So thank you so much, Dr. Arvind. Really appreciate that despite being so busy, both of you could take out time and join us in the chat today. Thank you so much, Dr. Arvind and Dr. Rahul. Really appreciate it.
Thank you.
Thank you. Thanks.
Thank you.